Hello, everybody. My name is Bryson Kemler. I'm one of the newer sports medicine orthopedic surgeons here at OrthoVirginia. Currently, I'm in our Chesapeake office, which is where I see patients, as well as at our Virginia Beach office. And today I wanted to give a little talk on something that I feel passionate about, which is shoulder injuries and throwers or throwing athletes. I'm originally from Mechanicsville, Virginia, outside Richmond. Played baseball growing up and ended up playing a little bit at William & Mary. And so that kind of got me interested in not only sports medicine, but especially in baseball players. So that kind of prompted this talk that I made a few years ago, but I think is still very relevant. So if you're in orthopedics, you see a slide or a diagram like this very frequently. And unfortunately, we don't have the GIF or the GIF that I had to go along with it. But this is the sort of wind up all the way through the follow through of pitching or throwing. And again, all of these sort of motions have been elucidated and different pathologies have been identified with all of them. And so I want to go through it in some detail just to give you some background and so you can identify if you are experiencing any of these or what can happen in a throwing motion. So we start with the wind up. And again, we had some good gifts of Dontrell Willis and others that could show you sort of what that motion looks like. And this is how you start your throwing motion. So in this phase, the rotator cuff is typically inactive. You have a stable center of gravity, but the balance in throwing starts here primarily with the lower extremities. And so when I'm talking to throwing athletes, I actually usually start with talking about their quadriceps and hips and make sure that that center of gravity is balanced prior to starting any kind of throwing motion. Because if you're unstable when you start, you're certainly going to expose yourself to potentially more injuries down the line. Next slide. The next phase is the early cocking or the stride phase. At this point, you're still not really activating your rotator cuff, but your deltoid muscle, the muscle on the outside of your shoulder, is experiencing its peak activation. And as your elbow is flexing and your shoulder is coming all the way back, you're externally rotating at really close to the physiologic maximum of what a human body can do. And you'll see that some of these pictures, especially as you get to higher and higher levels, can really push the envelope of what we even think is possible with external rotation in the shoulder. Next slide. So this is the late cocking phase, and this is the phase that's most associated with the Tommy John or UCL injury of the elbow. And so you can see with this image how far external rotation that shoulder is, as well as how much valgus or stress is on the inside or the UCL of the elbow. You're activating all of your rotator cuff throughout this whole motion. And as we'll look in a few slides, this is sort of the predecessor to some of the pathology we'll talk about, including internal impingement, GERD or glenohumeral internal rotation deficit, and slap tears in the shoulder. Next slide. The acceleration phase is as you start to come through in your windup and you're coming almost to ball release at this point. This is when you're internally rotating and flexing your elbow. And this, again, is really peak activation of the majority of the rotator cuff. The subscapularis is the large internal rotator of your shoulder. And so that's bringing the ball all the way around to the release point. And then some of the muscles in the back are also activated at this point. And so those would be some of the structures that are stressed here. Next slide. The deceleration phase, or after you ball release and are coming through towards the follow through, is when your center of gravity is moving forward and all of those sort of pent up kinetic energy that you've stored throughout the windup is released, and then it needs to be stopped. You need to basically decelerate through this phase. And so that's why this is considered the most harmful phase of throwing. Again, this is where you subject yourself to possible injuries of the labrum, including slap tears. The biceps tendon, where it attaches up towards the labrum, can become injured as it pulls forward. And then some of the muscles of the rotator cuff, including the teres minor, as well as even the brachialis down the arm, are all subject to injury at this phase. And so we call it, one of the more harmful points of your throwing motion. Finally, the follow through is when you stop, fully activating all of those muscles and you return to a resting level. And so this is when you've kind of gone back to your baseline. But you can see, especially with an image like this, how much you rely on the lower extremities through a pitching motion. You end up completely counterbalanced over your front or stride leg. And so with a weak base, you can see how that would really put your arm at risk. So one of the pathologies that I mentioned and what we could talk about now is this glenohumeral internal rotation deficit. This was originally described maybe 20 years ago by a few shoulder surgeons, James Andrews and Steve Burkhardt among them, when they noticed that in especially their higher level pitchers and throwing athletes, if they tested them maybe in a pre-season physical or when they started having shoulder trouble, they had a loss of internal rotation. So in this stock image, the rotation on the right side is less than on the left. And we see that in all sorts of overhead athletes, pitchers, tennis players, javelin throwers. And we weren't sure if this was just an anatomic sort of adaptation or if this was actually pathologic in the shoulder. But as you'll see in the next slide, we've seen that it actually can be pathologic and lead to some injuries. The idea is, as you come all the way back into that late cocking motion, and the back portion of your shoulder or the posterior capsule is really tightened, and it has to tighten because it's going to be such a violent forward motion that it needs to store that pent up kinetic energy. And so as you tighten that posterior capsule, then it's difficult for you to then loosen it and have internal rotation or forward motion. And so that's the idea of the physiologic adaptation of this glenohumeral internal rotation deficit. Next slide. So then as you've come through, the full motion and you get to the distraction force, the deceleration phase, there's an unbelievable amount of stress that's placed on that posterior capsule. And so that whole structure really has to tighten up in order to not be subjected to injury, considering a pitcher might throw 100 pitches in a game or more. And so there's a whole downstream effect of what happens when you have that contracted capsule. But essentially, it can lead to the injuries that I've listed here, including slap or labrum tears and biceps tendon tears. And sometimes you can even see all the way down to the capsule itself tearing. So it can be quite detrimental. Next slide. There are associated conditions, some of which are being studied kind of as we speak, because this is a relatively new phenomenon that we've discovered in especially younger athletes, kids that have started throwing and throw at high volumes throughout Little League and in the middle and high school, and they're still, have open growth plates. You can actually see adaptations in their anatomy as a result of this. And so this image here is a CT scan that shows the retroversion or the backwards version of the glenoid or the socket portion of your shoulder. And this is what's thought to be a result of someone who's thrown repetitively while their growth plates are open. And now that posterior capsule is so tight that they've actually changed their bony anatomy as a result. And so if you see this on a scan, you know that someone has been throwing at a high volume for a very long time. Next slide. So this is typically what I'll see in my clinic, or if I'm, checking out a baseball player or a javelin thrower, maybe in a training room, is they're obviously having some pain in their shoulder. Most of the time they describe it as vague, but they can isolate it to deep or towards the back. And then I always ask them about their velocity. If they throw their fastball at a certain speed and for the past few games or, weeks that velocity has dipped, that is a bit of an alarm bell in my head that their shoulder is not responding to the typical days of rest or their warm up or cool down. And so if they've got pain and velocity changes or a loss of control with maybe some of their pitches, then I start to think that this is a patient that needs to be evaluated. And the first thing I would do is lay them down, just like you can see in this diagram, and check their internal rotation. And so I always do it supine or laying down, but I measure first their external rotation and then second their internal rotation. And the number that we're looking for is 25 degrees. If there's a 25 degree less internal rotation on their throwing side than their other side, again, that raises a bit of an alarm for me. Next slide. This is just sort of, if you're someone who does examine shoulders, some thoughts as to what you should be doing when you look at it. The scapula needs to be stabilized, which is why if someone's going to be upright, you really need to have a hand on it while you're measuring their rotation. I like to do it in the supine position or laying down, just because the bed has a tendency to do that for me, and I can really focus on the rotation itself. But while they're sitting up, another way to check the capsule, the ligaments, and the labrum is to look for this sulcus sign, which is when you have a little bit of anterior laxity or laxity in the front of the capsule, which would correspond with tightness in the back. And so you grab the arm and pull down and check and see if there's any kind of laxity when you do that. Next slide. These are a couple of the impingement tests that I always try and test. They're not very specific, meaning, if they are painful, that doesn't necessarily mean that this patient 100% has impingement and it's not some other pathology that we discussed, but it can rule out some things. So if they can do these exams without much pain, then it doesn't point towards impingement as their main problem. But impingement is something we see across the spectrum in throwers, in patients of all ages and activity levels. And so this is a standard part of any shoulder exam. Next slide. The same thing with this Hawkins impingement test. This is a slightly different way of doing it, but by coming across your body, you close down the space above the rotator cuff, and if that results in pain, you know that there is at least some degree of impingement on that structure. And where that's coming from probably requires a little bit more either exam or potentially an MRI, but it's at least a good thing to test every patient with a shoulder injury with. Next slide. Some of the imaging that you might get if you're a throwing athlete with a problem and you come and see me or someone else about your shoulder is, I'm always going to do a physical exam like we've discussed. I'm always going to check your rotation, and I'll always evaluate your labrum, both standing and supine or laying down. I'll always get x-rays because that gives me an idea. Is this patient with open growth plates? Is this a patient with maybe some of those pathologic changes that we talked about? And if I'm really concerned about something like that, I might get a CT scan because that shows me good bony anatomy. But more likely, I would get either an MRI or sometimes an MRA, MR arthrogram, which is with dye injected into the shoulder, because that gives me a really good look at the labrum. In throwing athletes especially, I'm really trying to evaluate those intra-articular structures, the structures within the joint, which include the labrum, the capsule, and then right on the outside of that is the rotator cuff. And so an MRI or an MRA gives me a good look at those. Next slide. This is a stretch that I will always end the visit with any throwing athlete. I want to make sure that they're doing this sleeper stretch or this posterior capsular stretch. I think we've kind of discussed ad nauseum what goes on with the posterior capsule. Well, how can you treat that? And it's through stretching like this. And so this demonstrates a patient lying on their side with their throwing arm up, and they're pushing it down with their contralateral arm to really stretch that posterior capsule. And I make patients and throwers demonstrate this to me before I let them leave, because I want to make sure they're doing it correctly. Because at this point, we know that if that posterior capsule gets too tight and they have that internal rotation deficit, that's someone that's set up for having a problem down the line with their throwing or pitching. And so I want every thrower from Little League all the way up through the professional ranks to not only be doing this stretch regularly, but to be doing it correctly and to demonstrate to me that they know how to do it. Next slide. Surgery is obviously, what I do. And so I have operated on this. I don't love to do it because shoulder surgery in a thrower is usually something that takes a long time to recover from. Then there's a whole process of, returning to throwing itself. And so I only do it when there's something I can treat, something that I can make better. And so typically for just that posterior capsule tightness, or that glenohumeral internal rotation deficit, I focus on that sleeper stretch and some of the other physical therapy exercises that we can do to try and alleviate that. But if, some of those tests like the MRI shows either rotator cuff impingement or possibly tearing, or, if it's extended to the point of being a tear of the subscapularis, so the capsule, those are injuries that often need to be fixed with surgery. And if you have an unstable shoulder, if that shoulder is starting to come out of socket, then we might even need to discuss doing a bigger procedure like a Latarjet or moving bone to stabilize your shoulder. And unfortunately, for throwers that have shoulder surgery, their return to sport, and especially their return to high-level throwing, isn't as good as, for instance, Tommy John surgery or an elbow surgery, or a football player even with a knee injury. Throwers with shoulder injuries have a much more difficult time returning to their previous level if they have to undergo surgery. Next slide. Another question I get asked all the time about, and I see a fair amount in my clinic, is this Little League shoulder. And so what is this? Essentially, it's an overuse injury. And so you can see in this X-ray image to the right of the slide that in a patient with open growth plates, that if there's some widening, that outside aspect of the B image shows some widening of that growth plate, I know immediately that they have been stressing that growth plate repetitively. That doesn't just happen with a single, pitch. Sometimes a kid will say, well, I was pitching looked fine. And then all of a sudden there was this one pitch. It really wasn't that one pitch. It was a buildup over time. Maybe that one pitch sent him over the edge. But when I see that widening, I know that it's been overuse over a period of time. And you almost think of it like a break in the bone. I mean, it's an injury to the growth plate itself. And so it needs a pretty dedicated amount of time to heal. But as you can imagine, the most typical patient I see is, male, somewhere between 11 and 16, and oftentimes a pitcher. Maybe they're pitching year round. Maybe they're pitching for multiple teams, but they're throwing a lot. And then they come in with shoulder pain. And even just hearing that, I have an idea that this is probably what they're experiencing. Next slide. This is just getting into the nitty-gritty of sort of where the injury occurs. There are certain levels in the growth plate, and these are some of the phases of the throwing cycle that we talked about that incorporate into where that injury occurs. But typically, it's in this weak zone of the growth plate. And so if you're someone who is throwing, very hard, or throwing a lot of breaking pitches, or especially just throwing a lot over the course of a week, a month, a season, a year, you're repetitively causing some stress to this sort of fragile part of the growth plate. And by the time I see it on X-ray, I know that, there's been an injury and it needs some dedicated downtime. Next slide. Again, same sort of presentation as most pitchers. I'm going to ask them about their velocity, their accuracy. Are they still throwing strikes? And if not, if their pitching has changed and they're having kind of this shoulder pain or even pain that goes all the way down the arm, especially when they're getting to the back portion or the end portion of their throwing, then that's kind of when I think this could be Little League shoulder. If it's bad enough, sometimes you can actually palpate or feel along the edge of the bone, and that causes pain as well. And that's when I know it's a pretty significant injury. And then same thing with my exam, I'm always going to check their internal rotation and see if that's something that we can address at the same time as this growth plate injury. Next slide. I always obtain x-rays in the office. And again, I'm looking directly at that growth plate. If I'm really concerned, then I could either get an x-ray of the other side to compare, or more likely I would get an MRI just to see that there's no, complete break through the shoulder. This is almost never a surgical problem, but sometimes it gives me an idea of what the healing timeline might look like. But this is usually a diagnosis you can make based on talking to a patient, doing a physical exam, and just getting an x-ray. And so I feel pretty confident about that by the time a patient leaves my office, that that's what they're dealing with. Next slide. So, the timeline of stopping throwing can be variable, but 3 months is a good indicator of what you're probably looking at if a patient has true physeal widening or widening of their growth plate, because it needs downtime. And so for some players and kids, that might be a whole season. But like I said, it's usually a buildup of overuse. And so there's been a lot of discussion over the past decade or so into pitch count recommendations and interval throwing program and how to have healthy arm care throughout a season, whether you're a baseball player, a quarterback, a javelin thrower. And this pitch count recommendation has actually been verified by the American Orthopedic Sports Medicine Society. And it's recommended by them that these age groups stick to this and that they don't over pitch more than this, because if you do, you really open yourself up to those repetitive injuries. And so I'll show this to parents when they're in my office and make sure that we're sticking to these limits. So that's a little insight into the throwing motion and some of the pathology or injuries that can happen in these athletes. Hopefully it was informative for you. And if there are any questions, I'd be happy to take them.
Thank you so much, Dr. Kemler. It is time for questions now. So please leave your questions in the comments if you are watching live. We will do a mix of comments left live and ones sent in ahead of time. We will answer all that we can, but we may not get to all of them. So our first question is, what are growth plates? You've mentioned them a few times.
So when we're born, we really have minimal bone in our body. It's actually more of cartilage, and bones are made of calcium. So it is a calcium structure that will eventually form into bone. But as we grow, obviously our bones need to lengthen. And so as they turn into calcium, most of the bone is inert. It doesn't grow along with us. But there are specific areas along each of our bones, and the proximal humerus, or the top of your arm, is one of them, where there's an area where it basically grows. And so it will grow continuously. And so our growth happens in specific areas along our bones. And those areas we have termed growth plates. And so if you take an x-ray of someone who's not mature yet, who hasn't fully grown, you'll see these areas, almost spaces along their bones. And, when I look at a thrower who's not yet maybe 18 or older, then I'm looking at that growth plate. But that's essentially what that means.
Thank you. Our next question is, besides baseball and softball, what other sports can cause this kind of injury?
It's a great question. I see a fair amount. So, the title of the presentation is, shoulder injuries in throwing athletes, but it's anyone who's going through this sort of overhead motion repetitively. And so throwers may include baseball, softball players, javelin throwers. I see a lot of quarterbacks in football, but I also see players like tennis players who are consistently serving overhead. I see swimmers who in their freestyle or backstroke are coming overhead. It's sort of a repetitive circular motion. And so anyone who's got this sort of, a sport that they are repetitively overhead with force. And so if you have to bring your arm forward with a lot of force, these are the sort of pathologies and the problems that you think about.
Thank you. How can an athlete help prevent injuries from throwing in the first place? You've mentioned a few things about like a limited number of pitches, but what are some other things that the athletes can do?
Absolutely. Like I said, I always have a patient or an athlete demonstrate that sleeper stretch, because I want them doing that not only before they throw, but really every day. And so proper stretching and warm up is imperative. I mean, with the speed and torque and rotation that you're asking your arm to do 100 times in a practice or a game, you really need it to be completely warmed up and loose prior to doing that. And so stretching appropriately, making sure you're warmed up is really important. I do think that the best thing is to follow those guidelines on pitch counts. And so these days we're seeing a lot of AAU baseball or year-round softball, and that's great, but we're seeing more shoulder injuries. And so I think that if we're going to ask these athletes to do that and perform consistently year round, we have to be very mindful of what that's doing to their body. And so I think at a minimum, following those pitch counts and listening to your body, if you feel like your shoulder is starting to hurt, then seek treatment and probably shut it down for a little bit of time. And that will keep you healthy in the long run so that hopefully you have a longer career.
Thank you. Is it more important to have core strength or shoulder strength?
Core strength. Good question. If you think about the throwing motion, think of almost a whip cracking. And so, like I mentioned at the start of the talk, it starts in the lower extremity or the handle of the whip. I mean, the strength really comes from your lower body and core. And the shoulder and elbow are the very end point of that whip crack. And so you wouldn't strengthen a whip by making the very end point stronger. You'd strengthen it at the base. You'd make it thicker and, able to do that with more velocity and strength. And so anytime I'm seeing a player that has a shoulder or an elbow problem, I start with the lower extremities and the core. And even after a surgery, when they're downtime and shut down from throwing, I want them working on their lower extremity and core as soon as they can. So I would say, keep that very strong and be mindful of that during your off-season conditioning and whatnot, to keep your core and lower extremity strong.
Thank you. Can shoulder issues affect elbows?
Absolutely, and vice versa. And so I see a lot of athletes, especially throwers, pitchers primarily, who have elbow injuries. And if you've heard of, Tommy John surgery or Tommy John injury, UCL, that could sometimes just be a result of the downstream effect of having poor shoulder mechanics, that internal rotation deficit or, lesions in your labrum that have caused you to, end of the whip crack, force your elbow to do more. And so if you have something underlying in your shoulder, you're certainly more predisposed to having a problem in your elbow. And so if I have a patient come in with an elbow injury, there's a thrower, I'll examine both their elbow and their shoulder. And sometimes the treatment I prescribe is actually more geared towards the shoulder than the elbow.
Thank you. If somebody has a middle school pitcher for a baseball or softball team, should they just stick with that sport or should they be changing it up?
The recommendation has always been cross-training. And so that idea of early sport specialization, just sticking with one sport, I can understand if, a player is really passionate and maybe wants to have a long career, but when it comes to throwing, your body needs a period of time where you're really not throwing and asking your shoulder to do that much. And so if you're a pitcher and you like basketball or football, I would strongly encourage you to spend a season doing that and sort of doing that cross-training effect, because not only will it keep you healthy and strong, but it also trains some of the other muscles that you might not use as much as a baseball player. And so that makes you a better athlete in general, and at the same time as keeping you healthy. And so it's certainly a personal decision based on what an athlete wants to do. But I'm not very much in favor of that very early sport specialization. I think if you talk to a lot of major leaguers, they played multiple sports growing up, and that's consistently borne out that those players tend to have less injuries. So I would encourage young athletes to do that if they want.
Thank you. If a young pitcher has pain around their shoulder blades, where is it likely that the pain is coming from? Is it likely from a shoulder injury?
Could be. It probably depends on, where exactly that pain is coming from, when in their throwing motion do they feel it. And so usually it takes a physical exam, maybe even an x-ray to make that determination. But the shoulder blade is where the rotator cuff originates. The muscle belly is over top of the shoulder blade. And then there are other muscles that stabilize the shoulder blade. And those are more in the back and underneath on the side. And so depending on where they have pain is where I'll focus the treatments. If they have pain that comes out towards their shoulder, or they have pain specifically with throwing motions, then I'm more concerned that it's their shoulder. If they have sort of this more vague pain that's towards the back, maybe the inner portion of their shoulder blade, I wonder if maybe they have something going on with the stabilizing muscles of their shoulder blade or scapula.
Thank you so much, Dr. Kemler. That is all that we have time for. Would you like to close?
Absolutely. Thank you so much for listening. I hope this was informative for you, and I appreciate all those great questions at the end. Again, I'm here in Chesapeake today, and I'll see patients over at our Virginia Beach office, but I'm happy to see any throwers, young athletes, or anyone with shoulder and elbow pathology. And if you have questions, please just let me know.